Let's get straight to it. The Rural Health Transformation Program is a $50 billion commitment, but the real question isn't funding, it's execution. This presentation is not about healthcare in general. It's about one thing. How do you actually deliver measurable outcomes under RHT and ensure funding continuity? And more importantly, why Briea is the only platform architecturally built to do that. RHT changes the rules. This is not a grant you spend, it's a system you perform in. $10 billion a year sounds large, but every dollar is tied to outcomes, reporting, and compliance. CMS is not asking, "Did you deploy programs?" They are asking, "Did outcomes improve and can you prove it?" Funding is no longer input-driven. It is outcome-certified. Now here's the real problem. Every CXO, every state, every system is asking the same questions, and no one has a clear answer. How do you ensure daily adherence? How do you scale without doubling workforce? How do you generate continuous CMS-grade evidence? There is no established operating model for RHT execution, and that gap right there is the biggest risk in this entire program. Let's quantify that risk. This is not theoretical. $100 to $300 billion lost annually due to non-adherence. $17 billion in avoidable readmissions, up to $18,000 per readmission. Now RHT does something critical. It makes these losses visible, measurable, and tied to funding. What was previously inefficiency is now financial exposure. Here's the uncomfortable truth. The current healthcare system is not broken. It's just not built for RHT. It's episodic. It depends on patient initiative. It relies on manual follow-ups. And the data confirms it. More than 50% non-adherence. Nearly 60% readmissions tied to execution gaps. These systems were built to deliver care, not to ensure it is followed. So what exactly is missing? RHT funds infrastructure. It funds providers. It funds digital tools. But it does not fund the execution layer. No system ensures patients act, care is followed, and outcomes are completed. As such, care is prescribed, but not executed. And that is where RHT programs will fail. This is where Briea comes in. Briea is not another tool. It is the execution layer RHT never defined but absolutely requires. It ensures continuous engagement, adherence enforcement, completion tracking, real-time evidence, and more. Briea converts intent into outcomes and outcomes into reportable proof. Let's be very clear and very precise. There is no platform in the US today that combines proactive outreach, powered by voice, WhatsApp native care delivery, multilingual AI, and continuous execution. Not in combination. And that combination is exactly what RHT environments demand. This is not a feature difference. It is a structural difference. Chronic disease is where RHT wins or loses. 90% of healthcare is spent on that but has more than 50% non-adherence. RHT does not need better care plans. It needs execution of those plans daily. Briea ensures medication adherence, lifestyle compliance, diagnostic completion, as such execution of care plan in total. Important to note that in RHT, adherence is not a metric, it is the outcome which counts. Most digital health solutions fail the moment they hit rural America. Why? They assume broadband. They assume app literacy. They assume engagement behavior. RHT cannot afford those assumptions. Briea removes them entirely. No app. Voice first. WhatsApp native. If the patient cannot engage, the program cannot succeed. Briea ensures engagement is not optional but it is built in. Behavioral health is the silent driver of RHT outcomes. 1 in 5 adults affected. $19,000 excess cost per unmanaged case. And yet most systems detect it too late. Briea flips that model. It has proactive screening, continuous monitoring, structured escalation, and more. Behavioral health becomes measurable, continuous, and auditable. Let's talk about what actually drives RHT funding. That is data. No data, no compliance. No compliance, no funding. And here's the critical gap. Most systems reconstruct data after the fact. Briea generates it in real time, based on every interaction, every action, and every escalation. This is not reporting. This is live evidence generation. Now consider workforce. Rural healthcare cannot scale through hiring. The shortage is structural. If RHT depends on human scaling, it will fail. Briea changes the equation. It automates outreach, follow-ups, and routine engagement. Staff can focus on care as the system handles execution. That's how you scale without adding cost. This is the single most important difference. Traditional systems notify, but Briea initiates. Traditional systems wait, but Briea follows up. Traditional systems assume, Briea does not, it ensures execution. Non-adherence is not an awareness problem, it is an execution problem. We cannot blame user for that. And Briea is built to solve execution. RHT is not one problem, it's a system problem. The problem relates to chronic care, behavioral health, diagnostics, prevention, post-discharge care, and more. Most solutions address one of them. Briea integrates all into one continuous execution layer. One system, one patient journey, one evidence stream. That's what RHT actually requires. Let's bring this back to economics. $17 billion is readmission cost. $100 billion plus is cost related to non-adherence. Up to $900,000 savings can be achieved from small improvements. Briea directly impacts all of these. So this is not a technology decision. It is a financial protection decision. Briea protects outcomes, and obviously outcomes protect funding. Let's close this clearly. RHT will not fail because of lack of funding. It could fail because of lack of execution. Without an execution layer, there would be low adherence, weak reporting, and higher funding risk. Briea ensures continuous engagement, measurable outcomes, real-time evidence, and importantly, strong CMS alignment. The decision is not whether to deploy technology. The decision is, do you have an execution strategy or not? Briea is that strategy. Let us talk and move on.